This week on the Physio Foundations podcast, I'm talking to Dr. Luke Nelson, aka Sports Chiro Luke, about running and running-related injuries. Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. I'm your host, Luke Perrotin from Monash University Physiotherapy, and this week I'm welcoming back a guest from way back in episode 13 of the podcast, and that's Dr. Luke Nelson. And if you enjoy your podcasts, and you've probably heard from Luke before, he's really active on social media, particularly on Instagram as Sports Chiro Luke, and he's very active as well within the professional associations in our country, in Australia, such as Sports Medicine Australia and Sports Chiropractic Australia. And he's also run a sub 3-hour marathon, which I'm itching to ask him all about since he announced that he did that. And we're also going to talk today about working with runners in the clinic. So there's lots to chat about. Luke, welcome back to Physio Foundations.
Thanks very much for having me, Luke. There wasn't enough complaints the first time that I was on, so I'm honoured to be back again. I know you've had a few repeat guests as well. So I've enjoyed listening to the episode since then, and honoured to be back on.
No, there was lots of downloads, lots of interest, and people got a lot out of the episode. We dived into we're really talking in this. If you found this episode as someone who's generally interested in running, you should know that this podcast is for health professionals. If you find it interesting and you're, say, a running coach or a runner, that's great as well. But we're really, I guess as a caveat, we're talking to health professionals and health professional students, and you should always seek the advice of your own health professional for any problem you've got yourself. But if you do listen to it and find it interesting, that's great as well. Luke and I, last time, we dived into how he helps manage people in the clinic and guide them through running related injuries. That was a really interesting part of our last chat. So I was hoping to get back into that. But before we do, remind us all what you do clinically. So the sort of types of people you work with and special interest in what you do.
Yeah, so I'm in private practice in Melbourne, in a clinic in Mont Albert North. So I've been there now in that practice for 4 years, and before that was in another practice for 16 years. So just actually celebrated my 20th year in practice this year. We had a reunion with friends from uni, which was great to see where everyone has got to. But I've been based out of that clinic now for 4 years. Yes, a strong interest and passion of mine is dealing with runners. It's something that I reflected on years ago, the type of people that I loved working with, and I guess lit up my life and got my desire for practice. And so I then set about to, I guess, surround myself with more of those people. And so I attract a lot of runners into the practice. It would be probably, the last time I looked, about 40 or 50% of my caseload would be runners of varying abilities. And then the rest is a good mix of mainly other sports, things like Australian football and soccer and cricket and lots of things. So there's a bit of other stuff to mix it up a little bit for variety. But by and all, the majority is runners, recreational runners. So I see mainly a lot of lower limb related injuries, tendinopathies, patellofemoral pain, medial tibial stress, those sort of things there. And but then dealing with the other sports still keeps me going with shoulders and neck issues and all that sort of stuff as well.
Last time we chatted, you were in your clinic, and I could see in the background you had the squat rack, and you had all the treadmills and all the running related stuff in the background. So today you're recording from home. So
recording from home, we've got the Collingwood Premiership poster behind me there as well too. So that was so as a lifelong Collingwood supporter, it's been a good month here. So
for our overseas listeners, the Collingwood Football Club is Australian rules football, and they won the Premiership this year. So Luke's boasting away there about his team's victory. So that's you got to enjoy that. So
as I was explaining to some friends recently from the UK, they're like the Manchester United. They're very popular, but they're also very hated. So that's I guess a similarity drawn there between different sports.
They did well. It's their year. So So when you say you work with a lot of runners, or also those field sports, they involve running as well. So running is a big part of the management, or big part of the questioning and the thinking that you're doing with people.
Yep,
And
exactly, and that's where again, we look at running. I mean, running as a sport is one of the most popular global participation sports, but it is also a fundamental part of field sports as well. So obviously in our country, things like soccer, Australian football rules, and then overseas you've got things like lacrosse and other field sports as well too there. So it is a big part, and so again, that's where I do see a lot of even across those sports, a lot of lower limb related injuries as well.
Let's dive into a little bit more about maybe in continuing on from episode 13. If people want to go back and listen to that and continue on that chat we were having, where I was asking you about how you actually approach helping people, because there's so many different ways you can help people in the clinic. You can take different approaches and get to the same result. So I'm particularly interested in some of the more complex presentations as well. So how you help people with problems that are more chronic or persistent. So first of all, what do you prioritize when you first meet someone as a patient in the clinic and the main thing is running? They're doing a lot of running. And they've got an injury. What are some of the first things you look at?
So I guess the thing we've got to recognise with running injuries and injuries in general and pain is the multifactorial nature. So I think that I like it in that, especially in that initial consultation, it's some investigative work from our behalf as the health professionals. So we really need to be looking at the different contributors and what may have contributed to this injury. So we're looking at things like training loads. We're looking at things that we can talk a little bit about these as separate. We're looking at things like training loads. We're looking at tissue capacity, so things like strength and mobility, those sort of things there. We're looking at potentially biomechanics there. We're looking at different stresses and recovery as well too. So we're sort of encompassing across all those things. So to start with, I mean, I collect I get all my new patients to submit a form, which collects a lot of information on through there. So we like people to be sort of as thorough as they can, and then I'll review that before they come in. So I've sort of got an idea of what might be going on, and I guess where our conversation might go. And then I'm spending usually good 10 or 15 minutes just having a chat to the patient. So you mentioned before what's one of the first things that we do, but I think we need to develop that rapport and that relationship, fairly quickly in that initial consultation. So just listening to, I just say to the runner or to the patient, tell me your story, why you're here today, and let them sort of start to go on. And if they need to be guided into or drawn back on the path a little bit, then I do that. But we mentioned before in the previous episode the importance of listening, and so it really is just listening to their story about what brings them in today. They've also got one of the questions that I do ask on the intake form is, what are their expectations of their initial consult? What do they want to achieve with treatment, and what do they think is going on? So again, we can sort of see some of the things that they might want to be covered off today. So they, for instance, if it's a runner, they might sort of say, I want a running gait analysis. And so within that consultation, I've firstly got to ascertain if that's something that would be worth their while doing, if that's what's spending our time. If it's not, then I need to tell them why we're not doing that today. But if it is, we'll make sure that we and I think there might be some role there in their biomechanics, and that's something that we will ensure we have time to do. So sort of get an idea of what they're expecting as well of me when they're coming in. So after that 15 minutes, I mean, I work off a 1 hour initial. So then that leaves us sort of 45 minutes to then look into sort of further testing, and then where there's treatment or rehab there as well too as part of that. The training load, and we mentioned that before as well too. So training load is very important, especially when you are dealing with runners and recreational runners that aren't being coached. Because there's no school of running. We're not taught how to do it, what we should be doing, how much we should be training, rest days, intensity, volume, all these sort of things we're never really taught. And so I like to consider my role as an educator as well too. So I'm I love educating my patients and my runners and informing them, well, okay, instead of doing it this way, perhaps it's better to do this way so that we don't run into this problem again. So training load is quite important because that is a common common mistake that we see in recreational runners. There's usually two things. We see that they run too much too soon, so they're increasing their volume too quickly. And the second thing is they run too fast too often. So I call it the 4 2s: too hard, too much too soon, too hard too often. And so I'm looking at some of those things in their firstly just a discussion with them. So I'll sort of say, Luke, tell me a Monday to Sunday what your week looks like from an exercise point of view. So we're trying to capture that. I might actually get them to give me their Strava and pop their Strava up there, and we can have a look and see what their training history might have been like through there. And there's different other tools that I'll use also for looking a bit deeper into training load if I'm suspecting that there might be some contributors there. And so that's an important one for gathering their training stress. And I also do the same thing for really any of my active patients that give me a Monday to Sunday of what your training week looks like, because sometimes, and I had one the other day, is a talented youngster, and as they often are, playing 2 or 3 different sports, and you go through the week, it's like, well, you've got something on every day, if not 2 things on every day, and you've got this chronic knee complaint. I think we might need to have a discussion about training load there and modifying that. So like a lot of these things, you don't know until you've assessed them. You can't just assume these things. You have to sort of gather the information and then ascertain whether that's acceptable or whether that needs some attention and is part of their issue.
So listening is that foundation for you of that approach. So and thinking about and listening to people about what their expectations are, what they want to achieve, what they want to spend their time on, rather than you saying, well, with everyone I meet, I do a running analysis. What if you don't need that? What if you've already had one done? What if that's not of your interest? And sort of aligning expectations. What we talked about in the last episode, which I did my first YouTube short. Thank you, Henry. My 10-year-old showed me how to do it, and it was you. And he showed me, what am I? Generation X. So, and he's Generation Alpha, I think. He's 10. Right? So according to typecasting, everyone had put their generation. So he showed me how to make a YouTube short, and we got you there. And you were talking about that importance of listening and letting the person tell their story. So that gives everyone a really nice idea of your overall approach. Tell us a bit more about the injuries that people get when they run.
Yeah, so look, one of probably the more common the injuries that we see in recreational runners is patellofemoral pain, and not surprising, it's given the nickname of runner's knee. So that's probably one of the more common things that we'll see in recreational runners. Also, medial tibial stress is one of the more common ones. In sort of, I guess, more experienced runners, we're looking at things like tendinopathy, so Achilles tendinopathy, some of the foot pathologies like plantar heel pain, and you can see some patellofemoral pain, some patellar tendinopathy. ITB again tends to be more in your recreational runners around there. So usually a lot of knee issues. Throw in some hamstring tendinopathy there as well. Glute tendinopathy sometimes in older ages, and some hip issues. And then we've got the nasty ones like the stress fractures, and thankfully I don't see as many of those, but certainly see them. And you've always got to have your ears pricked up for those. And recently we've had a couple of actually femoral neck stress fractures. One off the back of someone doing the Melbourne Marathon a couple of weeks ago, and developed a femoral neck stress fracture just from that. And so you've always got to be aware of those nasty injuries. Don't want to miss those.
Well, the road running is so much harder than the trail running on your body.
It is. They are very different. They're very different scenes, and I've got patients involved in that in the ultra scenes, and then I've got the road runners, and having done a bit of both, they are a different crowd. I think that gets drawn to both. I mean, I think your road runners are very much more the obsession with pace and getting fast and doing that. Not to say that the trail runners and ultra runners aren't fast at all, but it's a very different, it's a long sustained suffering that they're doing, being out there for 12, 24 hours out on a track. But very, very different people, and there is again a bit of a mix of different injuries as well too. You see, I mean, with the trail runners, you've got throw in there your acute injuries as well too. Things like they can trip and fall, so you've got your ankle sprains and fractured ribs from people falling and that sort of stuff as well. So that does keep it interesting. Well, let's talk about running speed and surfaces and how they relate to those injuries. So you sort of touched on some of that. You said ITB, you see that more in the recreational runners, maybe with patellofemoral pain as well.
tell us a bit more about how fast you're running and how that influences some of those
Yeah,
pathologies
so
you might end up
I
with.
mean, Rasmus Nielsen did some work looking at this in terms of categorizing injuries by whether it was more likely brought on by sudden changes in volume versus sudden changes in pace. He tended to find that those sudden changes in volume where they've done too much too soon. So going back to those 4.2s before. So those that were brought on by sudden volume tended to be more your knee related pathologies. So things like your patellofemoral pain and your ITB. Whereas those that were brought on by sudden changes in pace, so that they've either done, they've increased their speed work, or they've introduced it, or they've done an extra session there, they've gone particularly harder on a session. That's where you might see things like Achilles tendinopathy, plantar heel pain, and calf strains as well. So, and that's not to say that's not the steadfast rule, but as a general rule. We also see in terms of elevation as well that can play. So we see, especially downhill, and I've experienced this myself too. Going, doing a course and running particularly hard downhill, I was very sore in the pulled up sore in an ITV a couple of years ago. So downhill running is quite hard on the knee, because the quads and our knee are basically the decelerators of our body mass. So as our feet hit the ground, their job is to stop us essentially falling forward. And so when we're going downhill, we've got an increased flight phase, and with that greater ground reaction force, and essentially those quads are working a lot harder to decelerate our mass. So they'll be put under greater stress there. So running downhill is harder on the knee, whereas going uphill, it tends to be harder on through the calf and the Achilles and the foot there, because they're the muscles that propel us up. Now, one can argue that what goes up comes down. So usually when you're doing a course, you've got equal uphill and downhill there. So when we sort of say, have you done a lot more downhill running or uphill running? Generally, just looking at changes in elevation can give you that. So that's something that, again, you can gather through their Strava profile or their Garmin as well, looking at their weekly elevation and sudden changes in that as well.
It's so useful to have so many people with so much data, because of the widespread uses of watches and all accelerometers and everything that sit in those watches. Amazing.
It is amazing. Like, I love being a runner as well too. And as you are yourself, they're often type A data-driven personalities. So there's a lot of information that we can get access to these days. I mean, I love to, looking into some of the data. So, there's some great apps which I recommend using, things like Runalyze, which is a free program to use to analyze training data. In our course that we teach, that's one of the programs that I recommend health professionals get used to doing when they're working with runners, is using Runalyze. I use Training Peaks, because that's what I also do running coaching as well. So I use that, so I can get the runner joining up to that and access their historical data, so I can actually troll through the stuff there. But yeah, again, looking at things like intensity and volume and elevation are some of the things to comb through there to see if what they're doing is the training wise is contributing to their injury. I mean, I guess technically by definition, any running injury running has to play a role there. So otherwise it would just be an injury. It wouldn't be a running injury. And so what we've got to see is it more a training load error is what we're looking for in the by looking at that data.
So training load, from what I'm hearing, plays a big role in what you're assessing, and also in some of these injuries. And I found that really interesting, your summary there of volume, pace, and elevation, and how that might sort of profile with some of the different injuries. It's a nice starting point for people listening to this anyway, to think about, well, is there a pattern in what people are doing?
Yeah.
Themselves?
And that's,
so,
again,
really
we're looking for, mistakes that they're making, because again, a lot of these injuries can be repetitive and recurrent. And so if we can educate the runner, as I said, if we're serving that role to inform them, and if they're saying, we can say, look, Luke, you've done this, and as you can see here, you've pretty much gone from 20 Ks right up to 60 Ks within a couple of weeks, and you can see how that's quite a bit of a challenge, a stress on your body there, and your body doesn't have time to adapt to that. And so in future, instead of doing that again, we can actually do a little bit more of a staggered process there, and that will lower your chances of ending up in the same situation there. So I think it's every injury provides an opportunity to learn and to educate as well.
There's some obvious stuff we need to do before we go for the more advanced top of the pyramid stuff, isn't it? The foundations.
Yeah, absolutely
the
right.
theme of the podcast. Yeah.
And I think it's where, there's often, people acknowledge that training load is an important thing, but in terms of how do we do that, I think is the, it's often given a bit of lip service as like, oh yeah, training load, but it's like, well, how are you actually going to assess that? And that's where, again, one of the things that I teach is using certain platforms and, from ranging from a beginner's way to do it, very simple and basic, looking at the graphs on Strava to doing a more advanced analysis and using platforms like Runalyze and looking at, training intensity zones and that sort of thing as well.
Yeah, and you've just been up in Sydney doing that course, teaching that course the other week.
It's been nice to. We created the online course the start of last year. I did that with the MAT group, so Movement Assessment Technology, and it's been nice post COVID now to get out and do face to face now. So we've done a couple of face to face courses and looking overseas into next year as well. So it's been great to do that and share my passion with lots of different health professionals.
Fantastic. Tell us a bit more about the more challenging, chronic, persistent problems. You mentioned medial tibial stress syndrome. You've mentioned tendinopathies and stress fractures. So these are, stress fractures could be a follow-up question as well, given the red flags and the other things that need assessing. But tell us how your approach differs when someone has something a bit more long-standing. They may have seen some other people before you. They may be frustrated. There may be some psychological or psychosocial factors.
Yep.
How do you tackle that?
Again, taking that approach of, all right, well, let's, consider that injuries are multifactorial, and let's really make sure that we're doing, especially for those quite complex and chronic ones, making sure that we're really ticking off all those facets there. So, we would have to do quite an in-depth delve into their training loads, because it likely hasn't been done before, unless they've been coached by someone. Certainly the psychosocial aspect of it can be really important. There can be even things like their recovery as well too. So asking simply, how many hours of sleep do they get a night? What they rate their nutrition as, and whilst that's not a validated outcome measure, it can just sort of start a conversation about some of these things. So I'll usually ask them to rate their stress out of 10, rate their nutrition out of 10, and then how many hours of sleep are they getting a night. And if they're sort of, stress wise, they're putting I'm a 10 out of 10 stress, and I'm getting 4 to 5 hours of sleep a night, there's going to be, you can bet there's going to be some discussions from my behalf to them about the importance of recovery, and no matter how much they're doing, they need to keep that balance. And I like to use a seesaw analogy with rocks, and having, on one side their stress and the other side their capacity. And we've got all these rocks on one side. So if we're putting work stress, training stress on this side through here, we're sleeping quite poorly. And then on our other side, we've got capacity. So that's, their fitness, their strength levels, their biomechanics, how they move. And if they've got more rocks on the stress side than on the capacity side, well, then that's where injury is going to result. So the way I explain to the runners is, well, look, we need to be either taking rocks off this side to get balance, or putting rocks on this side, or potentially both, to get things back into balance there. And so, telling them that my job is to work out where these rocks are and how we can move them around to get things back into balance.
That's a good analogy. So, I like it.
Yeah, there's also I know Greg Lehman's got his cup analogy as well too. So cup being the capacity and stress being the water that overflows. But for me, I've always just found the visual analogy of a seesaw. I've found it comfortable for me to explain it in that regard. And you're also recognizing that every injury is unique, and that's where one of the things I love and excites me about private practice is that you're never going to see two things the same. You can have one person with patellofemoral pain can have way different contributing factors to this person over here. One person might have just been done too much too soon. Their training load was terrible, but everything else is looking pretty good. And then you've got this person over through here that's got below average strength. They've got some biomechanical issues that may be putting greater stress on that patellofemoral joint there, and so the management is going to be very different for those two people. And I know that's sort of one of the challenges with when we're looking at research and at the literature is that you're always going to have, a heterogeneous group of people. You're never going to have everyone the same in that group. And so trying to put people into one group, give them one intervention and see what works, is you're always going to get sort of mixed results. And that is the challenge of research. And I know that you'd well and truly know that. And that's where I guess sort of taking that, I like to take I read a lot of the literature and I enjoy that and taking that and, trying to apply that into clinical practice, but recognizing that everyone is an individual. And that's where your clinical judgment comes into point of view into thinking, well, is this relevant to what's going on? Or is this just noise? Like, is this not relevant at all? That takes a bit of practice, I think, as well.
Well, the research should never replace or become a recipe or a replacement for clinical reasoning.
No.
And I think you've given a really nice summary of why that is. And sometimes research is, or the intention or the usefulness of research is a bit misinterpreted if you don't think about putting together your patient's views and your perspectives and clinical experience. And it's just something that should add to that. But
agree.
We digress anyway. I want to ask you about medial tibial stress syndrome. That's really tricky.
Yep.
So some background for people. What is it first, and how do you help people with it?
Yeah, so medial tibial stress syndrome is quite typical. It's typically, and I had one just 2 days ago, actually on Monday. They'll come in and they'll pretty much point to usually the mid-third of the shin. It's usually a spread over a few centimeters. So I'm always worried if they're coming in and, I'll say to them, where's the pain? So for instance, this guy that came in on this runner that came in on Monday, written on the new patient form, I've got shin pain. I'm like, okay, well, that could be anywhere. So the first question I'm going to ask him is, well, can you point and show me where your pain is? And he pretty much went like this with 2 fingers and when it's over this sort of distribution through there. So I'm already straight away thinking that's probably going to be medial tibial stress syndrome. If they're pointing with 1 finger, I'm a bit more worried. If it's a bit more confined, because that can suggest more likely to suggest a stress fracture. So we're always aware of that. So quite typically with these, they can behave a little bit differently. And there's some talk of, and I've heard others and probably seen a bit of this as well in terms of subtyping them between a bony sort of stress, medial tibial stress syndrome, and then almost like a periostitis, medial tibial stress syndrome. So they can behave a little bit differently. So you can find some that will warm up. So they actually, with exercise, they warm up, they feel a bit better, only to return later. And you can get those ones that they just do, the more exercise they do, the worse it gets. So there's sort of 2 different subcategories there. In terms of the actual cause of it, there was initial theories that's where the soleus blends and attaches in through there, or potentially the long flexors of the foot, that there's some pulling on the bone and the periosteum there, but it's not actually, doesn't really, the pain, the area of pain doesn't really correlate to that attachment. So that the current line of thinking is that it's more a bending force of the tibia that's doing that. So it is kind of on the spectrum of a stress fracture, but if you were to image them, they wouldn't show the signs of bone marrow edema that you would see with a bone stress injury. So in terms of the cause, we don't really know, but typically the symptoms are widespread, and from memory, I think it's 5 centimeters is the definition. I think isn't like 5 centimeters. So I'll often measure that. I'll sort of actually go, and this is what I did for this guy through here. So I'll palpate down and say, tell me when it starts to get sore. I'll put a mark there, or have my ruler next to me. Then go inferior start from superior, run down from the knee, run from inferior up from the medial malleolus there, and then you get a zone of tenderness. And then I just sort of mark down. I say, from 7 centimeters up from the medial malleolus, we've got a palpation area of 9 centimeters of pain. So, and I will actually track that, and I do find that does sort of narrow as they get better. It never narrows to a focal point, because again, that's more of a worry. If we see it go down to a single finger, then that can indicate that there's more likely to be a bone stress injury there. But that is something that I will track with those. Then it can be a mixed bag, actually, in terms of their capacity for that. Like I've seen this particular runner the other day had very good calf strength. So I do a lot of different calf measures. So I look at, standing calf raise to fatigue. He passed that with flying colours. I look at a seated calf raise isometric. He passed that with flying colours. Looked at some plyometric tests for him. A little bit down, but otherwise not too bad. We looked at his running gait. Yeah, not that bad either. And then also looking at, for him, we're looking at his training load, and that was a bit haphazard. So for him, we sort of identified that, training load was probably one of the things that we wanted to focus on for him. So again, it's that individual nature. Whereas I've seen others with this condition, and they've got very poor calf capacity, and their training's okay. So therefore, for them, the focus is going to be on building that strength in through the calf.
That's really interesting, the subcategorization that you've got there of some, and how it links to the behavior of some worsening and perhaps being more bony etiology, and the ones that warm up maybe more periosteal etiology. That's an interesting way of maybe explaining some of the differences we see between people. So now you're touching on contributing factors and the assessment. So obviously the calf plays a really important role biomechanically, not just in performance, but in sort of attenuating, for want of a better word, the forces that are going through your lower limb. And
anyone that knows me knows how much I love the calves. So
your Instagram,
calves.
Your Instagram is filled with calves and calf raise technique and training, and so big part of managing. Well, I mean, it's such an important. You've got such a important part of your efficiency in running as well, isn't it? Leverage through the ankle and
absolutely.
So tell us a bit more about management of taking someone from the point where when they come to see you. I imagine most people have had enough. It's affecting their performance, their training. They've probably tried other things.
Yes.
And then how long does it take? And how long until you can get people back to a more positive place?
Yeah, it's a really good question. And I know we've had a student observing the last couple of weeks, and we were having a chat about prognosis and expectations and what to tell people how long things are going to take. And it actually can be very very varied, especially when you're dealing with some of these chronic persistent issues, things like tendinopathy. I mean, we know from the research that can take sometimes 6 to 12 months for and plus and beyond for pain to go away. And so my discussion that I'll have with the runner is that, really, first up, for most running injuries, we can run with some level of pain. And I like to use Karen Silverknuckles, 4 to 5 out of 10 as being a guide. And people might ask, well, what does that mean? It just means that the pain's there, but it's not really getting to you. It's not altering your gait. And it's not, it's staying around that. That's what we sort of say, that mid to 4 to 5 out of 10. So I say that it's okay to have some discomfort with this, so long as we're not seeing it go above that during the run, after the run, or the next day. We know that we're on the right track there. Now, where these chronic conditions and things like medial tibial stress or tendinopathy, we may have pain for a while, but what we're going to see, and this is the aim of what we're going to be doing in our management, is we want to see your level of function. So the amount that you're running is going up. Now, even if the pain stabilizes, that's still a good thing, right? Because we're seeing that separation between function and pain. And that's where the emphasis starts. We start to draw them more towards function rather than being about pain and disability. And so to drawing them towards, well, look what you're able to do now. Yeah, the pain is still there, but now you're doing, 60, 70 Ks a week, and you're only able to do 20 before. And then before they know it, time may pass by and they're like, oh, actually, I don't even think I notice the pain anymore. They're so focused on what they're doing and not focusing on that pain. So I think that's a really important one for these persistent conditions, because the pain is likely to be there for a while. We need to sort of draw their attention away from that, and obviously making sure that we're not pushing it above that and making it worse. But yeah, if we can keep the runner going in what they're doing, one of my pet peeves is is those being told, "Oh, just, it hurts. My knee hurts when I run. Well, just don't run." And I think that's really lazy from a practitioner's point of view, because there's lots of things that they could be doing. Can they reduce their running? Can they run slower? Can they run faster? Can they run on a treadmill? Can they do some uphill running? Can they do some water running? Can they do something to get them back? But just blanket saying don't do it. Firstly, a lot of runners, it's part of their identity. Their social network are their running friends. They talk about running a lot, and so taking that away from them can sort of see them really spiral into some really negative psychosocial outcomes as well too. So keeping them involved as much as we can.
Yeah, that's a really important message. So especially, particularly with this condition, but with other conditions, the running volume might be going up, the pain may be the same. Yes. And that's really important to understand that from the patient education perspective. And you talked about aligning expectations between you as the practitioner and the patient. If someone doesn't realize that this will take a long time and it will probably have, you will need to run through some pain, then that's probably a difficult thing to figure out on your own as well. So
absolutely,
that's interesting. What conditions do you have the opposite message for when we think, okay, we do need to be using pain as a guide and not running through pain? I'm thinking of stress fractures.
Absolutely. I mean, they're the ones that we want to be, next to zero. I mean, there would be special circumstances where certain stress fractures, lower risk stress fractures where you could have some discomfort there, but they are special circumstances that, they've got an important race coming up. Everyone's educated in terms of what the consequences could be of running through pain with this. But certainly with stress, bone stress injuries, we really want to be keeping pain at a zero for that when we're running. So really having to, unfortunately for those, there is a period of offload for that, and that can be difficult. That can be difficult, especially with the injuries like your femoral neck stress fractures and your high risk stress fractures as well too, which can be some time off, and then it's a very slow gradual rebuild on the other side of it. So unfortunately, you do have to take running away from them. There's one of these femoral neck stress fractures that I'm working with at the moment. He's thankfully one of them is a triathlete, and so he's actually just happily swimming and riding, and he's doing well on that. And I sort of said to him the other day, I said, it's lucky you've got these two, because unfortunately, runners, that's often all they do, and they don't have any sort of outlet like that. And you take them away, and they're just like, well, what am I going to do now? They don't like the gym, they don't like bike riding, and they don't like swimming, and so it can be quite challenging in that regard, because it can be months of off deloading, and then it's a slow gradual rebuild.
Yeah. What about what conditions are somewhere in between? So you mentioned osteoarthritis before. You've got hip, knee, foot osteoarthritis is under-recognised. How much is too much, do you think, for pain in those conditions with running?
I'd probably put them with OA and things like, and working with a lot of masters runners, a lot of them have some of that going on. They may have some, chronic meniscal injuries that they're dealing with there as well too. So again, with those, like I'd still put them in the basket with that 4 or 5 out of 10. So we can sort of keep them going. And I think, a lot of people over the age of, once you get over there, I mean, I'm on the other side of 40 now. So once you start to sort of get to 40, 50, you start to accept that, I'm not going to be springing out of bed in the morning. I might be sort of, moving around a little bit. So it takes me a little bit longer to get going. So there is an acceptance that, we're not going to feel like we were 20. Or if they are expecting that, then there's probably some education on that's not reasonable to, on themselves to expect that. So I'd put them in the same basket as that. But again, I guess it also, I mean, there may be a discussion that you need to have about how much that's really worrying them and why that might be worrying them, like in terms of if they're like, well, no, I don't want pain, like, and whether you might need to have discussion and, well, why, what do you think's happening? And they might sort of say, well, my knee's crumbling or my knee's degenerating, or it's, if I'm running, it's going to be wearing my knees down. And, a lot of people have got the thought of that they're like a car, and just, the more you use it, the more it wears down. And thankfully, we are biological creatures that we can adapt and respond. And so we don't need someone to come in there and change our knees over. Our body does that ourselves.
There are a lot of good, positive messages out there about that. Do you think
I think there is.
Do you think that's filtering through
I think
to
so,
the general population in terms of what you see people coming in with? Do you think there's less of those unhelpful messages out there getting through to people? Or
I think so. Like, I think the runners know it, but I don't think that non-runners would know this. Like, we certainly see in the circles that I'm in, and it can be a bit of an echo chamber as well, where everyone's sort of saying the same message, and everyone's like, there's no, running doesn't give you OA. And I think that runners are probably exposed to that now, but non-runners aren't. Like, I still get people, non-runners saying to me, "Oh, what are you running for? You're going to get your knees are going to wear away," and so that it's still out there. There is still a bit of that attitude amongst some, but thankfully the people that run don't believe that, and that's probably the most important, because they're going to likely to keep going.
So a message I'm getting from here is that there's a range of conditions that ranging from short-term and less serious through to quite serious stress fractures, for example. A lot of them have common contributing factors. Training loads play a big part of them. Often people haven't had their training loads assessed as much as they could. And there's a lot of education that we can all benefit from.
Yes.
So when do you refer people for further investigations or to other professionals? Or when do you call it and say, I need to bring in other people in the patient management?
And I think having a team is really, really important. So, I've got certainly, if I suspect that there might be some further foot issues through there, I've got good podiatrists in my network. I've got sports psychologists, we've got sports doctors, we've got sports dietitians, we've got running coaches, all these sort of things. And I think when you're working with runners, having good shoe stores that you work with as well that can appropriately fit shoes. So all these sort of things, it's really important to have into your network. And I'm certainly fortunate to have some really good professionals and health and fitness professionals as well too, in terms of strength and conditioning in my network. So I think it really helps to have that, especially if you're working with runners, asking if they've got a coach and keeping the coach in the communication, because an injured runner for them is no good, because that's they're more likely to abandon their training plan, and so again, working with the coach to figure out, all right, well, what are some ways that we can keep them running? Get the more people you have working for the betterment of that runner, the better. And it makes runners are always really happy when they say, oh, look, can you give me your coach's email address? We're gonna send this plan to you, and I'm going to CC them in on it as well, so they know what's going on, they know the plan and how we're going to get back to things and how we're going to go about getting you back on the plan. And I've never had a runner say, no, I'm not going to give you my coach's details. I was like, yeah, for sure, please talk about it. If they've got a personal trainer, talking to the personal trainers about some of the things that the exercises that we might need to modify for the time being, but with the plan of keeping them going, keep them training. I don't think it's certainly not a good way to go about things. Just telling the runner to stop what they're doing. Firstly, we mentioned that the detriment of the runner themselves, but also, as I said, to those people that the coaches that's their livelihood as well too. So there's lots of things to consider there, and it's all for the betterment of the runner if everyone can work together.
And they're there seeing you because they don't want to stop.
No,
and they're
that's
looking for a
exactly.
way to manage that. So and they could have quit all on their own without your sage advice to just stop.
That's exactly right. You can do that on their own. Yeah, for sure. That's it.
What about sports doctors and other investigations? When do you bring in the sports doc?
Yeah, so I've been a good case, for instance, this recent femoral neck stress fracture, this bone stress injury. And so I tend to generally, if someone's had a bone stress injury, I'll get them to have a blood review with either sports doctor or their doctor if they're I guess involved in more active people. But I usually prefer working with sports doctors, and then I'll also get a review by sports dietitian. Now, again, I stress it's a review. It doesn't mean that you're doing anything wrong, and quite frequently you find, as has been my experience, that the runners are under fueling, and they're not doing it on purpose. They're not doing it to, I'm going to cut down weight, so I'm not going to reduce this much. They're just not eating enough. They're just exercising way more than they're consuming. And it was actually the case with this recent guy. I said to him, look, we're going to get a review here. He's like, yeah, I think my diet's pretty good. Okay, well, you're not a trained sports dietitian, and nor am I, so I'm going to send you to someone that is. Sent them to them, and they reviewed it, and they said, yeah, look, no, that isn't enough. And he's like, yep, all right, took that on board and already started implementing some of those tips as he's recovering from it. So, always I'm getting a review if it's a bone stress injury, especially if it's the more proximal ones. So things like sacral, pubic, or femoral neck are more likely to be considering sort of underfueling and maybe some red S as part of that as well. More distal ones like metatarsals, they can just be more training load related, but I think it's a good opportunity just to get a review anyway.
You just said red S. Let's define that. And at Sports Medicine Australia conference, which we were talking about before we pressed record, that Susanna and I were at, and you missed out on this year, unfortunately. There was a big keynote on red S, and that actually hit the local media, which was interesting.
Yep.
The local TV came in. So it's a very big deal, under-recognised, and now getting more recognition. Let's tell everyone what that is.
Yeah, so red S is relative energy deficiency syndrome. So it used to be what's called the female athlete triad, but they obviously accepted that it happens in males as well. In fact, most of the patients that I've had with it have been males, actually, surprisingly. So, what it essentially is it's underfueling, and its core part there is not fueling enough, and therefore what happens with that is the body can't replenish itself, and so obviously training breaks the body down, and we need energy to build that back up and build it stronger than what it was before. So it's not doing that. It will sacrifice certain things, and bone tissue is one of those ones that the body will, if it's thinking, oh geez, we're under stress here, we need to be getting energy from somewhere, and that will then stop that or slow down that bony rebuild. And that's where we sort of see things like they're more prone to bone stress injuries. We also see disruption to the sex hormones as well too. So in females, that's usually a cessation of their period. In males, that can be a drop off in their sex drive as well. So that is something that you do have to be comfortable with asking about if you're suspecting that might be going on. And your female runners, asking, do you have a natural period? Because sometimes if they're on the oral contraceptive pill, then that you can't take anything from that because that's a chemically induced period. So that may be something that you, again, going to and speaking to their physician or their sports doctor about that as well. If you're thinking that may be playing a role. So yeah, that's what red S, and it has been getting a lot more media attention in recent years. I mean, there was a runner over in the US, Mary Kane, who was part of the Nike Oregon project. That's now no longer, but that was quite public in terms of some of the things that she endured in her time as a professional athlete there, that was, almost body shamed and, for very much focused on weight, get your weight down. And what you often see with these is that, especially at the high level, they have, an obsession with weight. They try and cut weight. They may see an initial improvement in performance. They think that's great. They continue to cut weight. Improvement starts to decline. They think they need to cut more, further decline, and that usually then ends in injury. So there's also another quite well-known case, Tina Muir, who's a runner from the UK, and she hadn't had a normal period for 8 years, and she made the decision to stop running so that she could have a family, and thankfully she was able to do that shortly after stopping. But yeah, it's becoming a lot more normalised to talk about menstrual health, and so it's not sort of such a taboo subject, and really can be a quite a good reflection of someone's health.
That's a great summary, Luke. And one of the first things you said in this episode was, when I asked about running injuries, you said they're multifactorial. And if you think about the wide range of things you've touched on, not just contributing factors, but management strategies and thinking about the whole person. You've really given us an explanation of why you said that, why it is multifactorial. I'm conscious of your time, and you've got to get back to your work in the clinic. I can't finish this episode without asking about your running.
Yes.
You ran a sub 3 hour marathon.
At last.
That was at the Gold Coast, Australia, which is, for the overseas listeners, is halfway up the East Coast, where it's in the dry season. Do they have a dry season in the Gold Coast? It's more in the tropics.
Well,
anyway, it's in winter, so it's not super hot in summer, and it's a flat course where people go for their personal best. Is that right?
Yeah, that is what took me up there, and it took me a few tries to get there, but I was finally happy to do that, and that then enabled me to that qualified me for Boston, which I then also ran this year as well. So back in April this year, I went over and ran Boston, which was an incredible experience, and something that I'd one of the things that got me into running all those years ago was actually a patient who was going off to run Boston, and he was the one who handed me my first marathon training program. So pretty much 10, actually it was longer than that, sort of 13 years after that, I was able to run it. And I'm actually still connected with this patient. And he mentioned on Strava, and I said, well, that was, remember that time all those years ago, and so it was pretty cool to reminisce on those sliding door moments and what sort of the nudge I got back then. But no, it was a great relief to finally do it after failing 3 times. So it was a really happy achievement. So it was one that was down to a lot of persistence and just consistency was what got me there. I think if there was one thing to come out of the COVID lockdowns, there wasn't a lot of other stuff to do during that time. So I was enabled me actually to get a lot of training done, and that sort of gave me a really good base to then to get that run done last year.
Was it hot?
It was actually quite nice. It was a good day. It was good conditions, which was great. I'd previously that was the third or fourth time I'd run Gold Coast, and 2 other times before that I had felt the heat, but I'd sort of changed the way I was running this time, in that I was running a lot during the middle part of the day during my lunch break, and so I think that even just that extra 10 degrees difference between running at 0 degrees in the morning here in Melbourne versus 10 or 12, it was certainly a lot closer to the race conditions I was getting up there. So I think that helped prepare me a bit better for that. But it was a nice day. So everything just went well. It's probably my best run to date. So we'll see if we can eclipse it at some point. But if not, I'm happy to rest on those laurels.
How many? So I'm sorry I can't do it in miles.
Yes.
Minutes per mile, but how many minutes per kilometre is? That
was just under 4:15. Oh, well, actually 4:15 is a sub 3. I did. Was that 4? I did 2:54. Ended up running there, so which I think is about 4:08 pace. 4 minute and 8 seconds.
And what did it feel like taking a picture next to the timing board there at the end?
Yeah, it was just a relief after all the, and you see all our runners go through the same, and whether you're running a sub 3 or you're running a sub 4 or even a 5:30 marathon, it's just the sense of achievement. Like, I'm not running races to win them, and nor are the majority of my patients. You're trying to beat yourself, you're trying to better yourself, and maybe there's an incentive. And actually the guy that I went up with, his time was 2:54:30. So I actually sort of said, well, I'm going to beat his time today. So there was a bit of an incentive there to push me towards the end, and I snuck under by a few seconds. But it's just a relief to have achieved, what you set out to, and all the work and the sacrifices that you put into it, to know that it paid off was quite satisfying.
My best time was over 20 minutes slower than you, so you would have been sitting there on the finish line for 20 minutes waiting for me to come in. But I
would have waited for you. Would have waited with a big smile on my face. Yeah,
I remember that it's a phenomenal feeling because of all the endorphins and all the expectations and all of the camaraderie that goes along in those events. It's just very hard as well, and there's so much training that goes into it. And when you finish, it's almost not overstating it, but I think it's a life-changing experience for people. Fantastic.
Yeah, I mean, I was down for the Melbourne Marathon, and I did the half marathon last month. But I was waiting around after I'd finished, and just watching all the people finish, and I had lots of patients that were running it, and some of the runners that I coach, and it was just amazing. Like, I just sort of sat there and just seeing all these people that were, some weren't so happy they didn't get the time they wanted to. There were tears, there was laughter, there was hugs, and it was just it was such a great atmosphere. And again, just to see so many people, striving to do their best, and whether that's running 5 hours or whether that's running 3 hours, it was just really really inspiring to see.
or sub 2 hours, but that's a whole different beast, isn't it?
That's exactly right.
And you're doing a 1,500 meter track run this weekend.
Decided to switch the track in a couple of weeks. So something I'd always sort of said I'd have a go at, and this time of year I thought, nah, that's it. I'm gonna do it. I did some cross country over the winter, which I'd never really done before. Just sort of trying new things, and we say running, but really within running there's so much, isn't there? You've got your ultras, you've got your trail runs, you've got your road runs, you've got your park runs, you've got everything. So there's something for everyone, I reckon, and so I'm just sort of mixing it up and trying to certainly not looking to set the world on fire, but trying to set myself some goals and see if I can achieve them.
Fantastic. Well, any final thoughts, Luke? We've covered a lot of ground here. I think I've tried to summarise the themes as we're going. The themes I've taken away from this are we sort of hooked into the last episode. We talked about the importance of listening, and then exploring. We touched on the processes you use to assess people and manage them. But really dived into some contributing factors to running injuries. And one of the big things I got out of that was not just the multifactorial nature of it, but the fact that the training load plays such an important role in it, and the research supports that as well. And it's potentially not measured as well as it could be. But then we've got Strava and the other apps that you mentioned that are just sitting there waiting to be mined. So I found that really interesting. You had some really nice clinical tips for us in terms of the patterning of different injuries that can happen, and talked about speed and volume of running and elevation changes. Fantastic. Anything else? Any final thoughts you'd
I think just to summarise it all, going back to that multifactorial nature of injury, that initial consultation should be a real fact-finding mission, and going through talking about some of those things, looking at training load, looking at physical capacity, if you're getting time to do things like running gait analysis, that sort of stuff as well. And so I think, just trying to assess the individual on their merits, and then use your clinical judgment to ascertain what you think may be contributing, and working out a plan to keep the runner running, and get them to achieve what their goals are.
Well, I really appreciate you coming on and sharing all this knowledge with us. I certainly learned a lot. I hope everyone listening to this has learned a lot as well. So
hope so. It's always great to chat running. So it's been a pleasure to talk to you again today, Luke.
So you can look in the show notes. You can look at Luke's previous episode for. He's quite easy to find online if you Google Sports Chiro Luke or Luke Nelson. There are other Luke Nelsons in the world, but if you put chiropractor or Sports Chiro Luke in there, up he pops. You can find him talking about calf raises and many other things on Instagram, any other social media. You're on all the usual social media. Anywhere else that you want to direct people to? You've got your courses that you mentioned. For
with the Matt running course, we've got some still looking at setting some dates there next year, but sort of following through social media. We'll keep everyone updated through that. Either Instagram or LinkedIn is where I tend to be most active these days. So bit old for TikTok. I am on there, but haven't got quite the hang of that one. So
right.
But no, happy with Instagram. I think it's a nice, positive place, and sort of end up forming quite a number of friends actually through that too. So so no, anyone's more than welcome to hit me up and fire away any questions on there.
I mean, there's junk on the internet, of course, and there's all sorts of junk on social media, but there is some phenomenal resources on there as well. If you think about the quality stuff that people are posting on there, and your account is a good example. You can flick through there and see some really nice summaries in the same way that infographics will summarize a complex research article. There's a lot. If there's a simple message in one of your posts there's actually a lot that's gone into that simple message. So it's well worth checking out. So.
It's a great learning resource for, I've learned a lot from a lot of the people that I follow, and again, really love the network that and the community that I'm a part of and hope to contribute to as well.
Fantastic. Well, I can't wait to do it again. But thanks for now, Luke. It's been great, Luke. And we'll leave it there.
Thank you.
So until next time, this is Luke Nelson and Luke Perrotin wishing you all the very best with your studying, professional development, and lifelong learning.